Okay, this is a lecture on lysosomal storage diseases. And actually, lysosomal storage diseases are under the umbrella of inborn errors of metabolism, but they're a little bit different, so we're going to have a specific lecture just on this. Get this to move forward. So, lysosomes are intercellular organelles, and I like to think of our cells as very green. We are not so green, but our cells are very green. And so whatever we're done with, whether it be nucleic acids, carbohydrates, whatnot, we send them to the lysosomes to be broke down into small particles that can then be excreted from the cells into the bloodstream and then further removed or used somewhere else. Lysosomes contain a number of enzymes used in this to catabolize proteins, nucleic acids, lipids, complex carbohydrates. And each enzyme breaks down a different step of one of these processes. And again, these small pieces can then be eliminated. But defects in one of these, either breaking down proteins, breaking down nucleic acids, breaking down complex carbohydrates, can result in that product getting into the lysosomes because we're done with it and it has to get broken out, but it can't complete the process, so it gets stuck in the lysosomes. And then when it gets stuck in the lysosome gets bigger and bigger and bigger, and it kind of takes over the cell. So when to suspect a lysosomal storage disease? And one is organomegaly, having a large organ, because these lysosomes take over the cell, and then the cell becomes very enlarged and non-functional, and then we do with it what we do with it, whatever we have. You know, I think of the liver and the spleen is like the garage in the basement of our house. Just keep shoving them in there, and the next thing you can't get in. Unexplained joint stiffness. This accumulation results in joint stiffness. Coarse facial features, especially if it's progressing. And I'm going to show you some examples. It's a very vague term, coarse facial features, so we're going to go over this. Unexplained pain in children, burning, neuropathic, bone pain. And then finally, loss of developmental milestones. You know, it's one thing not to be moving forward. It's quite another to be moving back. I hate the word developmental delay. Unfortunately, it's here to stay, but it's quite a bit more concerning when a child is losing developmental milestones. So the first group of disorders we're going to talk about are mucopolysaccharide disorders, Hurler's, Hurler-Shea, and Shea. I'm going to have a number of questions. I'm going to start reading the question. We're going to go through that section, and then we'll go over the question again. And similar to these questions might be on your exam. Not the exact questions, but similar ones. Anyway, a study which can be used to determine if an individual has a mucopolysaccharide disorder is serum amino acids, urine organic acids, urine for glycosaminoglycans, lactic acid, or serum carnitine. So the pathophysiology of mucopolysaccharidosis type 1, or Hurler, Hurler-Shea, or Shea. Glycosaminoglycans, or GAGs, are large carbohydrates which are important in tissue support. And lysosomal enzymes break this down into smaller pieces so that it can be excreted. Deficiencies of alpha-1 iduronidase results in Hurler syndrome. So it's this step right here in breaking down the glycosaminoglycans to small components. So what the genetics of MPS I, it's inherited in autosomal recessive. I've said this before, and I'll say it like 12 more times. That way you'll remember it. If it's an enzyme that's deficient, it's probably recessive. Most people have 100% of enzyme activity. As long as you have 20, you're probably fine. So if one copy works at 100% and the other works at 0%, that's 50%. And I said, you're probably good with 20. So if it's an enzyme deficiency, I would pick autosomal recessive. The other option is X-linked, but if you want to be safe and you have no idea what the disorder is and they're asking you how it's inherited, just pick autosomal recessive. Carriers are asymptomatic. It affects all ethnic groups, and and it occurs in about 100,000 individuals. Physical features include coarse facial feature. And what does that mean? Well, we kind of have this short nose with these upturned nostrils, kind of this thick cheeks, really thick lips, the tongue's kind of enlarged, and we also have this contractures of the fingers. Usually they're normal at birth and this progresses over time. So here's a little girl at 10 months with Hurler syndrome. And you can maybe see the eyes. And here she is at 12 months, but who would ever choose, think that this child is dysmorphic? But then here she is at 22 months. And what is it that makes her look coarse? Well, her cheeks are getting thicker. Her lips are getting thicker. Her eyebrows are getting a little bushier, and here we are at 39 months. And again, her lips are even thicker, her cheeks are even bigger, and now her eyebrows are even bushier. So that's what kind of makes the difference. I always say that the ophthalmologist is my best friend because the cornea is a very thin membrane, and when there's a storage disorder, it's not unusual for it to accumulate on the cornea. So one of the main features of Hurler syndrome is corneal clouding, and it looks like a ground glass in there. They can also have glaucoma and retinal disease, ENT, chronic rhinitis, chronic otitis media, cardiovascular, valvular disease, cardiomyopathy. This is the most common cause of death. CNS, hydrocephalus, and progressive developmental delay. As I said, it's one thing to be moving forward slowly. It's another thing to be moving backwards. Some of the clinical characteristics of Hurler syndrome include inability to extend the arm all the way. You can see these contractures of the fingers, and this is called a gibbous, and it's kind of like a bump here in the spine. So diagnosis of MPS I, urine glycosaminoglycans, is an inexpensive screening test to look to see if this unmetabolized mucopolysaccharides are present in the urine. Dermatin and heparin sulfate are both elevated in patients with MPS I and MPS II. I'm going to talk about MPS II in a second. Enzyme analysis or molecular testing is needed to confirm the diagnosis. And most affected patients have less than 1% of enzyme in the case of MPS I of alpha-1 iduronidase. Also, this is more of a clinical thing than for your exam. As we start going through more, as molecular testing gets cheaper and cheaper, we're almost going backwards. We used to do these glycosaminoglycans, and then we look at the enzyme, and then we look for the gene. We're now doing gene testing, like exome and genome testing, finding out there's some funky gene for, lysosomal storage disease, and then we're checking the enzyme or, other things like that. So, clinical medicine is kind of going backwards because of the cost effectiveness of actually looking at genome testing. DNA analysis for the IDUA gene identifies 2 mutations in 100% of patients. So, for instance, if I had a patient that looked kind of funky, a baby, they just didn't know what was going on, and we did genome and we found 2 mutations of IDUA, then I'd actually do enzyme testing. Now, Hurler-Shea, and Shea were clinical diagnoses that were made long before we knew about these enzymes or, let alone the IDUA gene or anything like that. So they were named after people based on clinical symptoms. So the historical Hurler syndrome is most classic. Shea is a much milder form, and Hurler-Shea is a little bit more severe than the Shea. But they're all caused by various deficiencies of the alpha-1 iduronidase enzyme. And so Hurler's has no enzyme, Shea has maybe 6 or 8% of enzyme, and Hurler-Shea maybe has 3% of enzyme. It's a very vague term we don't use as much. I just wanted to go over it. Enzyme replacement. There actually is an enzyme, aldurazyme iduronidase, which has been approved and it's infused weekly. Early studies have shown improvement in organomegaly and skeletal features. However, these enzymes do not cross the blood-brain barrier. And so in Shea and Hurler-Shea, which are the milder, later onset disorders, they don't have the significant cognitive delays. It's actually very helpful for them. However, because it doesn't cross the blood-brain barrier, it's not as useful in Hurler's. One of the things they are looking at with Hurler's is a bone marrow transplant. It's actually transplanting the bone marrow so that the new cells, bone marrows, can get that enzyme across the blood-brain barrier. And that's actually the treatment that we use now. So a study which can be used to determine if an individual has a mucopolysaccharide disorder is serum amino acids, urine organic acids, urine for glycosaminoglycans, lactic acid or serum carnitine, and the answer is urine for glycosaminoglycans. So, as I promised, Hunter's is MPS II. X-linked, features similar to Hurler's, except for they present a little bit later, and it's only seen in males. We're going to talk about some other X-linked disorders. This one's only seen in males. Female symptoms, patients are asymptomatic. Features of Hunter's or MPS II include progressive developmental delay, hearing impairment, progressive thickening of the heart wall. These are all very similar to Hurler syndrome. Growth deficiency, aggressive behavior, but they do not have corneal clouding. So that's a differentiating feature between Hurler's and Hunter's. And there may be, though, progressive visual loss due to pressure on the optic nerve, but not corneal clouding. And there's also this nodular skin lesion. Diagnosis of Hunter syndrome, elevation of dermatin heparin sulfate, similar to Hurler's, enzyme deficiency of iduronate sulfatase, and again, there's enzyme therapy available as well as bone marrow transplant. As I was saying, if you're ever going to guess something, always guess recessive, but I would memorize like the excellent ones, like Hunter's. So, memorize the few excellent things and just, otherwise pick autosomal recessive. Sanfilippo, MPS III, there's actually 3 types, A, B, and C, and they're caused by different enzyme deficiencies. So Dr. Sanfilippo named a bunch of things after himself that are different, but they all say Sanfilippo. I hate that. Anyway, enzyme therapy is currently in study phases. So clinical features, I'm going to talk about Sanfilippo A. They have very significant hepatosplenomegaly. And one of the things, I think of Hurler's, affects everything. It affects the brains, it affects the joints, it affects the heart, it affects hepatosplenomegaly. Sanfilippo A has much more severe hepatosplenomegaly. They also have the coarsening facial features. You can see these kind of full, big cheeks and full lips, progressive cognitive delays, athetoke movements, but no skeletal involvement. So they do not have any skeletal involvement, and there's urine glycosaminoglycans only show elevation of heparin sulfate. And at this point, there's no treatment, but they are working on enzyme analysis, enzyme therapies. Morchio, however, MPS 7, has very, very severe skeletal anomalies. They also have the corneal clouding, aortic regurg, coarse facial features. This is a pectus carinatum, but they have normal intelligence, so it doesn't cross the blood-brain barrier. It's caused by the deficiency of the enzyme galactosamine 6-sulfatase, and it's autosomal recessive. And because it doesn't cross the blood-brain barrier, we have treatment available, which even though it's incredibly rare, there is enzyme treatment. And in the urine glycosaminoglycans show elevation of keratin sulfate. This is actually kind of an overview slide for lysosomal storage diseases. The next ones that we're going to talk about. So ganglioside, GM3, goes to glucocerebroside. When that's not working, this is Tay-Sachs. The ceramide trihexide goes to glucocerebroside. When this enzyme's not working, this is called Fabry's. Sphingomyelin to ceramide, Niemann-Pick. Galactocerebroside to ceramide, Krabbe's. and then glucocerebroside to Gaucher. So ceramide is this main player in the middle of this. So the next one I want to talk about is Fabry disease. And Fabry disease is caused by a mutation of the GLA gene, which is located on the X chromosome. Males usually start showing signs of this disorder early in adolescence. Early symptoms include the inability to sweat, rural keratopathy, which I'm going to talk about in a second. It's an ophthalmologic feature, pain and tingling in the hands and feet, and a non-blanching rash. And you might notice inheritance, X-linked, but I didn't say recessive. Heterozygous females with one copy of the gene that's on and one off, can have symptoms as severe as males. Some have no symptoms, and some have symptoms as severe as males. So it's caused by a deficiency of the enzyme alpha-galactosidase A, and it results in the deposition of this large chemical called globotransceramide in the vascular endothelium, and the glycolipid deposits in these smooth muscle cells result in obstruction of small capillaries and ischemia. The smallest capillaries that we have are in the kidney, heart, and the brain. So here's a little bit of animation. So here's our cell, and here's the lysosome. And normally we have our GL3 goes into the lysosome to be broken down with the alpha-galactosidase A, and life is good, and everything's recycled and wonderful. The problem is when we don't have this enzyme, the GL3 goes into the lysosomes, and it can't get broken down, so it just gets bigger and bigger and bigger. And then it starts obstructing, these large cells start obstructing small capillaries. And as I said earlier, the smallest capillaries are in the kidney, the heart, and the brain. So, in Fabry disease, the most common cause of death in males and females is stroke, renal failure, myocardial infarction, leukemia, or hyperthermia. Clinical features of Fabry disease include angiokeratoma, or non-blanching skin rash. So when you push down on this rash, it doesn't get lighter. Inability to sweat. The capillaries and sweat glands are very small, so especially males have a very significant inability to sweat, which causes them intolerance to heat and cold. And then tingling and pain in the hands and feet. Cardiac abnormalities include left ventricular hypertrophy and mitral valve prolapse and regurg, as well as premature stroke. Ocular findings, again, ophthalmologist, my best friend, rural keratopathy. This is kind of this whirl pattern, and this is actually seen more in females than males, probably because of the X inactivation. I've had a number of females come to my medical attention because of this. And so clinical symptoms in males, during childhood, they can have intense pain radiating throughout the body, burning and tingling, impaired sweating, which makes it hard for them to be outside. Like little boys, they'll turn all red. They can only be outside for a couple, 20 minutes, and their face is all red. Corneal clouding or whirling, frequent fevers, heat and cold intolerance, and this causes a lot of emotional issues. This is the malingering child that whines about everything all the time. By adolescence, now you're starting to see protein in the urine. They have stomach pains, diarrhea, nausea. That's the skin lesion starts showing, and then fatigue. And then finally, in adulthood, you start seeing impaired renal function, dizziness and headache, stroke, heart problems, hearing loss, and then ringing of the ears, or otherwise known as tinnitus. Women with Fabry, as I said earlier, can have symptoms just as severe as men. The thing is, the X chromosome is randomly inactivated. So what does it mean to have a small pocket of cells in your brain that the X that's on is the one that's not making the enzyme? So we have a group of cells that aren't making the enzyme. They can get large and obstruct those small capillaries, and that's called a stroke. In the heart, a small pockets of cells that are obstructing, not making the enzyme can obstruct small capillaries in the heart, and that can result in a heart attack. The kidney, you know, you only need a quarter of one kidney to have normal kidney function. So there might be little pockets of the kidneys that are functioning correctly. And depending on where they are, they can have elevated protein sometimes in the urine. They might have a mild increase in their creatinine. However, females usually do not go into renal failure. Having said that, they need both of their kidneys. So they are not a good candidate to be giving a kidney to a brother or cousin or somebody else in the family with Fabry's disease, because they need both of their kidneys, and it's not the best option for the person that gets it because half of this woman's kidney is already damaged by Fabry accumulation, and it won't be a good option. So, as I said earlier, microvascular disease is the main issue in these cells. There's occlusion of the small microvasculature in the kidney, heart, and the brain, and this results to death of the tissue by ischemia. Cardiovascular disease is the most common cause of death in males and females. So cardiovascular disease, not renal disease, is the leading cause of death. So therapy biweekly, so every other week, enzyme replacement has been shown to slow the progression of renal and cardiac disease. There are actually 2 enzyme products available in the U.S. New therapies that are being looked into, one is called a chaperone, and these are, I'm bringing up in this particular presentation, but this is how they're looking at treating a lot of these different disorders. A chaperone is something that helps the protein work better. And they actually do have one chaperone medication that's currently FDA approved. They came to me, you know how drug reps come, oh, this will work in half your patients. I have one patient out of 60 that this actually works for, although a lot of my patients are from similar families, so they have the same mutation, but it's very mutation dependent. Substrate reducer. You know, a substrate reducer is something that if you can't break it down, don't make as much. So it blocks the first step of the synthesis, and it's effective in about 95% of patients. There aren't any that are FDA approved at this time, but it's just a concept. And then a chaperone so chaperones and substrate reducers are both oral medications, and these small chemicals can pass the blood-brain barrier. So in Fabry's disease, the most common cause of death in males and females is, and it's actually myocardial infarction. A 48-year-old Caucasian male of Ashkenazi Jewish descent is noted to have hepatosplenomegaly and thrombocytopenia. The most likely diagnosis is familial idiopathic thrombocytopenia, Fabry disease, Gaucher disease, hemochromatosis, or name and pick type C. And so the next disorder we're going to talk about is Gaucher disease. Gaucher disease is also inherited in autosomal recessive fashion, and it's caused by a mutation of the GBA gene, with the N370S being the most common. And it's caused by a deficiency of the enzyme glucocerebrosidase. It's the most common of the lysosomal storage disorders. And type 1 is present. 1 in 500 individuals of Ashkenazi Jewish descent have type 1 Gaucher disease. And so what's the problem in Gaucher disease? The problem is breaking glucoceramide to glucose plus ceramide. Remember that slide I showed you a while ago about ceramide? Through this enzyme, glucocerebrosidase. Features include fatigue, thrombocytopenia, hepatomegaly, growth retardation, pathologic bone pain, neurologic degeneration, anemia, splenomegaly, avascular necrosis, osteopenia. So here we have something called an inclusion body. This is like a path thing. And the other thing that's very specific is these Kupffer cells. They look like newspaper around it. Like these are the kind of things that Path loves to ask about Gaucher disease. These large macrophages, these are the large macrophages. So clinical manifestation, these abnormal accumulation results in abnormalities in osteoclasts. They can affect the Kupffer cells in the liver. They can cause avascular necrosis in the bones. enlargement of the spleen, and they can also affect respiratory alveolar macrophages. So clinical characteristics include a big spleen and liver, which causes this abdominal distension, bone disease, thrombocytopenia, anemia, growth retardation, bruising and bleeding because of all your other hematologic issues, fatigue, bone pain, and abdominal pain, because if your belly is that big, it will hurt. So, symptomatic treatment, hematologic, iron and vitamin supplements. Again, Gaucher disease has been described for over 100, probably close to 150 years. And long before they knew what caused it, they knew that these patients had anemia. So the treatment for anemia is iron and vitamins. If they're really anemic, a blood transfusion. If the spleen's way too big, take it out. Skeletal pain management, joint prostheses for the avascular necrosis, fracture management, again, osteopenia, the calcium supplementation in attempts to try to improve, and then core decompression. Specific treatment, enzyme therapy. So that last slide is what you do to treat the symptoms. What do you do to treat the disorder is enzyme replacement. And it's, historically it was given every 2 weeks, and we've had enzyme replacement for close to 30 years. There's also oral medications, and there are 2 therapies which are now available. So therapeutic effects of enzyme replacement, hematologic, and so we have a lot more evidence, like long-term evidence on this. So hematologic, 2.5 grams per deciliter increase in hemoglobin in 9 months and 50% increase in platelets. Hepatomegaly and splenomegaly, 20% decrease in the liver size after 9 months of therapy, and 45% decrease in the size of spleen, assuming that they haven't had a splenectomy. Another concept is a substrate reducer, and we talked about that a little bit in Fabry's disease, but Gaucher disease, this is actually FDA approved and really the standard of care. So we have enzyme therapy, but this is actually the one that we use. A substrate reducer inhibits the synthesis of glucocerebroside. And so hopefully whatever little residual enzyme that you have will take care of what's left. These are oral medications, and there's currently 2 in use. And the only thing we do is we do pharmacogenetic testing to make sure they're not what we call ultra-rapid metabolizers. If they metabolize this medication, the substrate reducer, too quickly, then it's not going to work. But other than that, it's not specific on a mutation. And this oral medication is now standard of care in adults. Unfortunately, with kids, it takes forever to get anything approved. So we have symptomatic kids. We put them on enzyme therapy until they become adults, and then we switch them over to the oral therapy. GBA gene carriers. As I said, 1 in 500 individuals of Ashkenazi Jewish descent have Gaucher disease. A lot of people are carriers before you have somebody. Remember, you both have to be carriers, and 1 in 4. It's recently been noted that carriers for 1 non-functional copy of this gene have an increased risk of tremors in their 50s to 60s. And it looks very much like Parkinson's disease. So carriers, usually a carrier has no symptoms, but now we realize carriers of this do have a kind of a Parkinson-like symptoms. So, a 48-year-old man of Ashkenazi Jewish descent is noted to have hepatomegaly and thrombocytopenia. The most likely diagnosis is Gaucher disease. Okay. A 6-month-old male has lost developmental milestones, including smiling. He has startling spells. The family indicates the parents are both of Ashkenazi Jewish descent, and consanguinity is denied. There's concern he may have Tay-Sachs. When is enzyme analysis, or which enzyme analysis is recommended? I don't know why it says when is. Iduronate sulfatase, hexaminidase, alpha-galactosidase, hexaminidase A, and alpha-glucosidase. So, I'm going to talk about some additional disorders, and the first one I want to talk about is Pompe disease, which is actually a lysosomal storage and a glycogen storage. And symptoms include progressive muscle weakness characterized by hypotonia, head lag, delayed milestones, Respiratory complications include infections and sleep apnea, and significant cardiomyopathy can result in early death. And here's a picture of this baby's heart. It pretty much takes over the whole chest. 92% of babies with infantile Pompe disease have significant cardiomegaly. EKG, because of that cardiomegaly and non-functional heart, show shortened PR intervals, a tall QRS complex, and Wolff-Parkinson White picture. So babies with Pompe disease have failure to thrive, usually postnatal, feeding problems, increased sucking and swallowing, poor weight gain, and moderate hepatomegaly and macroglossia. Again, cardiomegaly, elevated CK, plasma creatinine kinase, and elevation of liver enzymes, including AST and ALT. Confirming the diagnosis, enzyme analysis, looking at alpha galactoglucosidase, or GAA. GAA can be looked at on a blood spot. The other thing is looking at biopsy. Healthy myofibrils are replaced by glycogen. We don't do this too often because it's kind of invasive. But what you're seeing is accumulation of glycogen. And this accumulation of glycogen in the muscles results in hypotonia. And because the baby has low muscle tone, they can't eat very well. So treatment, management. They actually did a movie on this with Harrison Ford. Symptomatic treatment, PTOT. It's not, you're treading water upstream. You're not going to get very far. Myozyme is an enzyme replacement available in clinical use, and it actually received FDA approval faster than most any enzyme. And I've been talking about how difficult it is to get anything approved in children, and this is actually one of the few that got approved very quickly. Bone marrow transplant. Well, you can do it and it'll work, but imagine you're transplanting a 5-month-old with cardiomegaly on a bench. The mortality was close to 90-something%. But the mortality of Fabry's is pretty horrible too. So here we have the survival curve. This is just similar survival curves of 2 different studies of children with infantile Pompe disease, and they're all pretty much dead by 10 months. And then they took some kids and put them on enzyme and compared them to the classic curve, and the kids on the enzyme were surviving and making developmental progress. A couple of them, 15 out of 18, were doing great. Lost a couple, but the vast majority were doing great. So after a couple months, the FDA actually looked at this. It wasn't like you have to, do any kind of statistical analysis. You just look at this and say, oh my gosh, I got to do something. So the FDA actually approved this as a therapy. One of the things we realized, though, is there's infantile Pompe, but there's also an adult onset, which, it's not like 0 enzyme results in infantile Pompe, but maybe 4% enzyme is still not good. So one isn't working at all, and one is working a teeny bit. And that's more the adult onset, and it's far more common. So you have deficient enzyme. Clinical features include proximal muscle weakness, so difficulty going upstairs, standing up from a chair, elevation of CK, cardiomyopathy, and restrictive pulmonary disease. It looks a lot like limb-girdle muscular dystrophy, and enzyme therapy is also very helpful in this group. And next, Tay-Sachs disease. Tay-Sachs is caused by a mutation of the enzyme hexosaminidase A. It results in lipid accumulation in the neurons of the ganglia, and this is kind of this cherry red spot. Remember I was saying Hurler's affects everything, and Morquia only affects the joint, Well, Tay-Sachs only affects the brain. The one thing we really can't do anything about. And so the baby otherwise has no other unusual features, no contractures, no hepatomegaly. It's autosomal recessive. 1 in 30 individuals of Ashkenazi Jewish descent are a carrier for Tay-Sachs. One thing, though, I'd like to emphasize, though, is the general population is 1 in 300. People of Ashkenazi Jewish descent have been doing carrier screening for Tay-Sachs for the past 3 generations. To actually see a baby with Tay-Sachs You know, it's usually not in the Ashkenazi Jewish population because most individuals of Ashkenazi Jewish descent know if they're a carrier of this. And so there is still a general population risk of this disorder. Truth be told, I thank God never seen a baby with Tay-Sachs, and I hope never to. Neiman Pick, like the San Filippo, some guy, Neiman and Pick, named a bunch of things that have nothing to do with each other, types A, B, and C, and they're all caused by the inability to break down lipids. It's a lipid storage disease. Deficiency of sphingomyelinase in type A. There's severe neurologic disease in the first few years of life. It's, again, common Ashkenazi Jewish population. Type B, no neurologic symptoms, but enlarged spleen and liver. And then type 3, unable to metabolize cholesterol and lipids, resulting in accumulation of lipids in the liver and spleen. Progressive ataxia, can present in infancy. Gene testing is now available, and there are some clinical trials using medications that help to clear cholesterol and lipids from the cell. So, a 6-month-old male has lost developmental milestones, including smiling. He has staring spells. The family indicates the parents are both of Ashkenazi Jewish descent. If they're ever telling you in a question what an ethnic background of the family is, there's probably a reason for it. Consanguinity is denied. There's concern he has Tay-Sachs. So you're like going through this going, yay! And then it's like, but they already told me this. So what enzyme is abnormal? And the answer is hexosaminidase A. So, in conclusion, enzyme therapy cannot cross the blood-brain barrier. Therefore, disorders, lysosomal storage disorders with neurologic effects are not well treated that way. Early diagnosis can help in better prognosis. As treatments become available, earlier diagnosis is important in prognosis. And actually, in Illinois, the newborn screen, we've actually added most of these lysosomal storage diseases to the newborn screen, although they will never ask you on step what's on the newborn screen because it's not consistent from state to state. And, you know, this early diagnosis will hopefully identify, help us start earlier on long-term treatment. And the correct diagnosis also allows for counseling the family. So I'm going to go through some USMLE test questions that I found so we can just go through it. A 50-year-old female was recently diagnosed with a movement disorder, Parkinson's disease. The family is positive for her father who was diagnosed with Parkinson's at 60. She has a 55-year-old brother who has Gaucher disease. He has no symptoms of movement disorder. What gene is likely related to her symptoms? So again, there's a movement disorder that often is diagnosed as Parkinson's. She's got a brother with Gaucher, which means there's and her dad had also a movement disorder. So there's a 2/3 chance she carries a mutation of the GBA gene. And again, I took these out of board exam books. A 2-year-old is diagnosed with a biochemical defect involving hexosaminidase A. The patient's condition would be best appropriately categorized as belonging to which of the following defects: in amino acidopathy, gangliosidosis, carbohydrate metabolism, mucopolysaccharide, or porphyria. And this is Tay-Sachs because it's hexosaminidase A. Most kids are gone by age 2, but anyway, and so that's that. And here's a joke slide. I've gotten rid of most of my joke slides, but since it's only insulting me, it's probably okay. Okay, so that concludes this lecture.